Top Med Talk.
Welcome to Top Med Talk. Don't forget to check out the show notes for this week's episode for more information about how to handle diabetic patients. Today's Top Med Talk is taken from EBPOM 2021 and is introduced by Mike Grocott.
It's a real pleasure to introduce this session, which is joint with the Centre for Perioperative Care. This is the second year that we've run CPOC EBPOM sessions together, and this is the first of two sessions that we have. It's a delight to welcome the Director of CPOC, Dave Selwyn. Would you like to introduce yourself a little bit and tell us a little bit about CPOC?
Thanks. As you've heard, I'm the Director for the Centre for Perioperative Care. So CPOC is a cross-specialty collaboration dedicated to the promotion, advancement and development of perioperative care for our patients at all stages of their surgical journey. And it's just over 2 years ago since we started this initiative. It was launched in May 2019. I think CPOC now has established itself really as a powerful voice, certainly in the UK health practice for perioperative care. And I just encourage people, if they want to know more about CPOC, to go to our website, which is www.cpoc.org.uk. And
we've got a very broad-based group pulling CPOC together.
Yeah, exactly. So we've got a CPOC board that has a variety of professional stakeholders on it, and the membership is constantly under review. We've got membership from the College of Anaesthetists, Royal College of Physicians, the Royal College of Surgeons of England, the Royal College of Nursing, the Royal College of General Practitioners, the Faculty of Public Health, the College of ODPs, who are a new member, the Association of Anaesthetists, and the Royal College of Paediatrics and Child Health, as well as those professional stakeholders. We've got trainee representation from the Academy of Medical Royal Colleges, and also we've got a number of patients who are present on the board. So, as you say, absolutely key to have wide stakeholder engagement. And I think one of the successes that we've had is with Scarlett, who's going to be talking shortly, and Jagdeep, who's hosting a session tomorrow as deputies. They bring the voice of the surgical voice and the physician voice right to the centre of the discussion. So really pleased that they contribute so much to the success of CPOC.
And one of the big successes of the first couple of years has been this guideline, hasn't it? The diabetes guideline, which is going to be our focus today. So I'm going to hand over to you as we co-chaired.
Sure. So this guideline was released in March 2020. CPOC was commissioned by the Academy of Medical Royal Colleges to produce a whole pathway guideline on perioperative care for people with diabetes undergoing elective and emergency surgery. We're going to bring in Gerry Rayman, who was involved in the production of the guideline.
Good morning, David. Good morning, Mike. Thank you very much for inviting me to present at the meeting today. The CPOC guidance on diabetes has been really very welcomed by the diabetes specialists and their colleagues, and equally, I know, by the other disciplines involved in perioperative care. So it was a fantastic working group, and we produced this guideline within a year, which I think is pretty phenomenal. And the great thing about the guidance is actually it is very multidisciplinary, with a significant patient focus, obviously.
So I was going to ask Gerry, really, just to summarise what the guideline is all about and what it isn't about.
Okay, a little bit of history in that we developed a guideline in 2011 from the Joint British Diabetes Societies, which was well received by anaesthetist surgeons and diabetologists, but was never implemented to the extent that we had hoped, although it was very welcomed and considered to be the state-of-the-art guidance and updated on several occasions. As I say, the implementation was poor. So that led us to go to NCPOD because we were obviously disappointed and recognized that despite the guidelines, there was continued poor care for people with diabetes. NCPOD, as a result, undertook a review of perioperative diabetes services, the results of which were quite alarming. And that led the Academy of the Royal Colleges to approach CPOC to look at the development of the perioperative guidance for people with diabetes. So, as I said, it was very multidisciplinary. And that, I think, is the key thing with this guideline. The previous guidelines, although we had a surgeon and anaesthetist on it, that was the limit of the multidisciplinary working, whereas this has got a much wider group, a great deal of buy-in. And the other great thing, like the JBDS guidance, it starts from the referral, from primary care, all the way to the discharge. And it involves all the disciplines. But what's unique about this guidance is a section for each of those disciplines. It's a big document, You don't have to read the whole document. So you as a general practitioner or practice nurse, all you need to do is read your section, what you need to do in the referral process. And equally, there are sections for ward staff, there are sections for recovery, theatres, and so on. There are a large number of recommendations in each of those sections. And again, that's all that those individual disciplines need to concentrate on. The other brilliant thing about the guidance is CPOC. The organisation itself is clearly a desire to get this implemented. And we as a diabetes community share that enthusiasm for making sure that we deliver better care for people with diabetes. After all, they have a longer length of stay, they have more complications, and we know that we can reduce those very significantly. And indeed, a later speaker here, Emma Page, is involved in implementing a perioperative pathway within our trust, and that pathway reduced length of stay for people with diabetes down to the baseline population. So we eliminated the excess length of stay in people with diabetes and significantly reduced post-operative complications, as well as the complications related to diabetes, such as hypoglycemia and DKA occurring in hospital.
Brilliant, Gerry. So if I just summarise that then, so this is a new guidance, it's multi-professional, it's got all the stakeholders involved in the development. It's from the start of the perioperative referral process all the way through to recovery, which is different. It's broken into sections so people can dip in and dip out. There are, a large number of recommendations, 13 recommendations for organisations, 16 for primary care, 9 for the surgical, a whole host of recommendations. But one of the other bits that is different about this guidance is implementation. So CPOC are working on helping with a toolkit to help with the implementation, and we'll discuss that in a bit. Then the final aspect is that within the recommendation, there are a series of research questions that the group feel need answering, which again is unusual for a guideline, I would say.
And those research questions are quite essential. For example, we talk about good control prior to surgery, but does it need to be 3 months? Does it need to be an HbA1c of less than 8.5? Can it be a 3-week period or 2-week period of good control? We don't know the answers to that. We do know that glycemia during the perioperative phase is associated with worse outcomes. How do we achieve good glycemia with preventing hypoglycemia? So there's a lot of work to do, but I think the most important bit of work is getting everyone to work on the pathway.
So our next guest on the sofa, snuggling up alongside Gerry, is Scarlett, who's representing the surgeons, Scarlett McNally.
It's nice to be here. I'm a consultant orthopaedic surgeon in Eastbourne, which is on the south coast of the UK and is lovely. And I'm deputy director of CPOC, which has been really interesting. I've been involved just over a year. www.cpoc.org.uk. Please, everybody, look at the resources, send your patients there, send other staff there, because we've got loads of stuff going on. It's very heavily funded by the Royal College of Anaesthetists, for which we're very grateful. I've also been on the Council of the Royal College of Surgeons of England for the last 10 years, but I'm staying on CPOC even though I'm stepping down from the Council of the College of Surgeons. It's been lovely actually working right across the pathways, and this pathway with diabetes really exemplifies that way of working. So it enables the other members of staff, the nurses, receptionists, other practitioners, allied health professionals, to know really what ought to happen in general. And once you know what ought to happen in general, you know if your patient is kind of falling off the normal pathway and needs some very individualized, targeted specialist care. And otherwise, you can empower the other members of the staff and the patients to know what the right thing to do is. And I think that's been revolutionary, this way of looking at it.
From a practitioner perspective, the pathway focus, I think, is really neat and something that I really hope CPOC continues to do for other guidelines. Any particular take-homes, things that maybe you thought of or focused on beforehand that are coming out of the process?
Well, with the diabetes guideline, I think the problem is you don't do tests unless you're going to act on the result. So sometimes preoperative assessment feels like people are kind of collecting information and needing to write it down, but not doing anything with it. And suddenly we've got something that you can do something with it, you can improve outcomes, and people have their diabetes managed much better. People who have their general lifestyle managed much better. Nutrition, focus on nutrition and exercise and activity to try and get them as fit as they possibly can be for their operation, means you'll have fewer complications. And that's the thing that surgeons are desperate to achieve. So from my point of view, there's about 5 million people in the UK with diabetes. So that's 8% of the population, and it's a higher percentage of people coming for an operation. And yet each one we sort of act as if it's a surprise. So what we really need, or what we have now, and do look at cpoc.org.uk and then just put in the search bit diabetes, you will find the whole guideline. It's free for everyone to use. You've got a page of what patients really ought to do and a page of what pre-op assessment ought to do and that kind of thing. It shouldn't be a surprise. But critically, if you do things as what best practice, what the evidence shows, you get people fitter, you get people coming through the surgery better, and you have fewer complications and shorter lengths of stay. And that's what surgeons need, but it's also what patients need and what the service needs. Yeah, it's a different way of looking at it. And it might just be that it's that teachable moment that helps someone for the rest of their life. The point is that it's really important and that it's worth doing. And kind of up until now, it was just one of those things people measured but didn't do anything about. So that to me is the critical point.
Okay, so the next guest is Goher Ayman, who's a representative from Diabetes UK, one of our patient representatives who's been on the guideline group. So just in terms of being the patient representative on the group, why did we need a new guideline and what's the aim of all of this?
From the patient perspective, it's about understanding that you're in good care, that you will have the best care possible as well. Obviously, they've seen it in the surveys and audits that are conducted, but from the patient perspective, what I've heard on the grapevine as well as across all different groups of different people with diabetes is that the care is hit and miss, and it could be really excellent in places, and in other places there could be barely any acknowledgement of their diabetes in the course of their care, and the variation is huge. I think it led to a feeling of fear even about going into hospital to have treatment. The fact that their diabetes would either be snatched away from them, their management be snatched away from them and left to people who perhaps don't understand it as well as they do, versus people who want a diabetes holiday. So I think the guideline was timely in the sense that it filled the gap, particularly around looking at the whole perioperative period. So what happens right the way from when you're being considered for surgery all the way through to your discharge, but with the focus on diabetes. I think prior to this, it was really focusing on the immediate time around the surgery rather than as wide as from primary care, community care, all the way through to right at the end when you go back home. And it does break it up into the nice sections so that it's really clear who does what when. So it's never forgotten about. And I think that was another part of it, is that there was a lot of feedback that said one group was assuming the other group was dealing with my diabetes, whereas nobody was, and the patient was left entirely on their own and unguided. And I think this is where this guideline will certainly fill that gap. It will make sure that somebody is responsible and accountable somewhere along the way to talk to the patient and to discuss and agree together the course of their care in terms of their diabetes. So I think it's going to fill those gaps in the main.
And Scarlett challenged us during the production of this guideline to keep it as simple as we possibly can, and I'm not sure we achieved that necessarily. But one of the key things that I think came out for me in the discussions was that actually, by and large, the patient knows more about their diabetes than the clinician who's treating them. They know what is right for them and what is wrong for them. And so what we tried to do was to put relevant aspects in the guideline to empower the patient to have that ownership. And as you described, the shared decision-making. Do you think we achieved that, or did we miss that?
I think you've achieved it through encouraging communication, because I think when a patient goes in, either they feel confident enough to sort of self-advocate or they don't. And I think mostly they don't. And they don't know what questions to ask or how to speak about or raise their concerns about their diabetes care. And I think the guideline particularly brings in the opportunities to do that. I mean, you mentioned about empowerment, but it's really about giving the platform to speak and ask those questions at all the stages. So it's a prompt for the healthcare professional side, but also the patient side to say, well, this is actually the right time to talk about this, and you should speak about it all the time, all the way through, and make sure that you're happy. And I think the language has changed in the sense that it does promote that joint decision making and that acknowledgement that the patient is perhaps the expert of their diabetes more than this person who's seen them just for that short period of time. And everyone's individual and everyone has individual needs. So it doesn't impose self-management, for example. It said, well, do you want to self-manage over your time in hospital? Are you capable of that as well? So it asks those questions. And I think that's one of the most positive things about this is it gives the patient the choice, more of the choice of what happens with their diabetes care than perhaps others did before.
I've got a couple of questions. We've got one come through on Slido. Before I raise that one, we talk about supported self-management, which is something I hear a lot around different conferences and groups at the moment. Is that an expression that sort of lands well and feels comfortable from a patient perspective?
Yeah, I think so. I think there's differences in what people expect from a number of factors. So the type of diabetes and how you manage your diabetes varies quite widely. And certainly as we develop more and more treatment options, you can have somebody who's managing diet alone. If they're type 2 diabetic, for example, and they manage their diabetes purely with diet, their concerns are going to be very different to somebody like me with type 1 diabetes, managing my diabetes with a closed loop system. The requirements between us will be very different and our expectations of what the care level should be. So going into hospital with a closed loop perhaps would scare the healthcare professionals just as much as it would scare me, to be honest. The fact is I live with my diabetes every single day, every single minute, and I do understand what happened with my diabetes in certain conditions. And obviously the length of time that you've had your diabetes as well will affect how much you know about self-management needs. But then to expect somebody who doesn't know any of that to then look after me in a potentially novel situation is quite scary. So I think that self-management terminology makes sense very much to the diabetes community because we do that, we live with it, and it makes sense to offer that option when you're in hospital as well. But I think there's that sort of caveat saying that this could be a very novel situation for us. So most of us, thankfully, don't go to hospital very frequently for operations. And to understand and predict what's going to happen with your diabetes over that time is difficult to do anyway. So to kind of assume that someone should self-manage automatically is wrong, just the same as taking it entirely off our hands as soon as we get through the door.
So we should see this as more of as a partnership. Well, obviously, unless we're specialist diabetic physicians, we need to explore with you what you want to do, what we should be doing, but make sure at the end of the day that all the bases are covered, I guess. Question from Slido comes from Lawrence Murford, celebrating the fact the patient is focused throughout the guidance. Can you give the top 3 benefits that a patient would expect to see from the guidance? It's almost, I was nervous of these exam questions where you have to give 3 points, but there you are, you're on the spot.
The first thing will be improved communication about their diabetes. There's varied experiences, so acknowledgement in the first place of the diabetes is a key part. So if that's completely ignored through someone's care, it doesn't bode well for their experiences and how safe they feel. Certainly an improved communication about the diabetes, certainly an improved management of the diabetes as well during their time around and in the hospital. And hopefully that will feed out into better outcomes. So we're not staying in hospital unnecessarily. First on the list, considered first for day case surgery if that's an option. That our diabetes management isn't interrupted unnecessarily just because they want to put us on a sliding scale, when we can perfectly manage on our normal routines. And I think that's just going to make for a much more smooth and comfortable process for the person with diabetes. It's just one less stress to think about. Going through operation is awful anyway. It's highly stressful. And to have to worry about the diabetes management on top and the potential implications of losing that management or having bad management over that time, it's just nice to be able to not worry about that and make sure it's all properly agreed and considered all the way through. I think that's going to be a benefit. I probably listed about 20 there rather than 3. I'm sorry.
Great answer. I'm going to ask Dave to introduce our final speaker.
We're going to bring in Emma Page, who's an Improving the Perioperative Pathway of People with Diabetes program lead, who has also worked with the Get It Right First Time program. Emma, welcome.
Thanks, Dave, and thank you for inviting me along today. So I am the IP3D, which stands for, as you say, Improving the Perioperative Pathway of Patients with Diabetes, Programme Manager for GERFT, and I was also the project manager for the IP3D project, which started at Ipswich Hospital. So historically, Ipswich Hospital, like many of the other hospitals across the UK, had really struggled to implement sort of previous diabetes perioperative guidelines. Going very much on what sort of Goher's been talking about, we actually decided to try and put the patient at the centre of the pathway, and we came up with the idea of a diabetes perioperative passport, which is basically a handheld document that contains all the information that a patient would need to know about their diabetes care during the perioperative period, split into various sections. Information for the patient to actually provide about how their diabetes is normally managed, information for healthcare professionals to be able to provide information back to the patient. So, for example, for the pre-op team to be able to kind of circle instructions for medication prior changes that might be needed prior or post-surgery. And then the bulk of the passport is about giving the patient information about what to expect in terms of their diabetes care once they come into hospital. The passport is handed out in a pre-op assessment, and the idea is that the patient brings that along to any of their appointments related to their surgery and when they come into hospital, and that they can use that information in the passport to challenge if things aren't going quite as they feel they should be. So, for example, if they're on a variable rate insulin infusion and that gets taken down, they can kind of challenge the healthcare professionals and say, actually, why are you taking that down? I haven't had my insulin yet. It says in the passport, you shouldn't be doing it at that point. So we rolled that out, and we had some really good feedback from patients and also from staff with the passport. But we rolled it out with a number of other tools to help implementation as well. And one of the key things that we did was to set up what we called our IP3D group, which was basically bringing together colleagues from diabetes and from surgery to facilitate kind of better conversations really and better communication, to look at kind of what was working well within our trust and look at where we could make improvements. Part of that led on to developing diabetes surgical study days. So within our trust, we had previous diabetes days that staff had attended, but they tended to be largely attended by those on the medical wards. And the days are very kind of medical based. So the feedback we received from surgery is actually that they would like a more kind of tailored approach for staff. So we set up surgical study days that kind of looked at all the areas that staff working in theatres, in pre-op assessment and on the surgical wards would need to know about diabetes. And not hugely in depth, but kind of key things around sort of knowing how to recognise DKA, knowing how to treat hypoglycemia, knowing what to do if someone's blood glucose was high. And then from those surgical study days, we recruited diabetes perioperative champions, which were kind of people who were really enthusiastic on those days, and then who led on championing good perioperative care in their particular areas, whether that be pre-op or theatres or surgical wards. We also did quite a bit of work with our CCG as well. So one of the things we picked up in our pathway, and it's obviously mentioned in the CPOC guidelines, is around the quality of referrals that are coming through for surgery. So we found that quite a lot of the referrals didn't contain any information around mentioning diabetes at all, or including recent HbA1c. So we did a lot of work with the CCG to try and automate some of that information being pulled through, but also promoting to the GP practices why that information is important. We also did some work around improving documentation as well. So particularly for our day case patients, within our hospital at the time, we didn't have any sort of pathway for patients with diabetes who were having day case. So one of the things we did was to create a really kind of brief double-sided document that just kind of had the key information about a patient's diabetes, so their kind of blood glucose levels and whether they were on insulin, and encouraging staff to kind of use that opportune moment as well to do foot checks to check on the quality of feet as well. And then kind of key to the whole pathway really has been the recruitment of a diabetes perioperative specialist nurse. And we recruited at Ipswich and in the 10 trusts where the IP3D programme has been rolled out with GERFT. We've recruited those nurses from mainly a surgical background rather than a diabetes background. in so much that we haven't wanted to impose sort of diabetes onto surgery, but we've wanted it to be a joint approach. And those nurses have spent time being sort of upskilled in diabetes. And now they run pre-optimisation clinics where they work with patients prior to coming into hospital to optimise their diabetes control. They also work with patients whilst they're in hospital to make sure their diabetes is being managed well. And a real key part of their role is around sort of staff education and making sort of staff aware of sort of good diabetes care and kind of upskilling staff in being able to do that. And then, as Professor Rayman, as Gerry said earlier, we've had the results that we had in Ipswich were really, really positive. We had a reduction in length of stay from 4.6 days down to 3.3, which is the same as our background population of patients without diabetes. And crucially, we didn't have an increase in readmissions because we were worried, obviously, if we get patients, having shorter period in time, will they end up coming back into hospital with further complications? But we had a reduction in complications and we didn't have an increase in readmissions. And more importantly than all of that is that it's been really well received by patients as well, that they felt that the new pathway, they had better care for their diabetes.
Brilliant. That's a whole series of tools for implementation, some examples there. And I know when the guideline was being developed, one of the key things that the group were focused on was around the role of the diabetic specialist nurse. So I'm not surprised that you've taken that forward. I was going to ask you about the outputs from this, but yeah, I think you described that, and certainly a 1.3 reduction in length of stay is really impressive. Have I got this right? This program now is rolled out to around 10 trusts. Is that correct?
Yes. So Goher picked up on the programme and it's been rolled out to 10 pilot trusts across the country. So we've got a real mix. We've got trusts sort of up in the north of England, in the midst of England, in London, and a few in southern England as well. So each of those trusts has recruited a diabetes perioperative nurse and has used the kind of tools that we developed at Ipswich Hospital, has kind of amended them locally to fit their kind of local pathways. But one of the things that's kind of been key really is trying to get those trusts to understand their data and to know their data and to know what's kind of working well in their trusts initially and where kind of the areas for improvements were. And it's been different in each of the trusts. So it hasn't been, exactly the same issues that each trust is facing. But the key is, like I say, to try and get them to understand that. And one of the ways that they're doing that is through audit. So they are collecting a lot of data around the whole pathway, right through from referral to discharge, but also patient feedback and staff knowledge feedback as well.
We can bring in the rest of the panel. I mean, one of the roles of CPOC is not necessarily to reinvent the wheel, but it's to take examples of good practice, and we've just had some great examples there, and then to sort of make those resources available and publicised. And we've certainly got a number of case studies that are available on our website to help or to give people some idea around this.
I guess the question, which we talked about a lot when we were preparing the guidelines, is where next in terms of implementation. So the IP3D, if I got that right, it sounds like a great project and it's been picked up by Goher. So we're going to have a national rollout. It's a question, I guess, for Gerry and then others to join in. What's going to happen next? What should we expect?
I think the IP3D project has been good in Ipswich, but that's one trust. The question is, can it be rolled out to others? That's where we went out to these 10 other trusts. So if it is transferable, and certainly picking up on the feedback that we're getting, which is very, very positive from the other trusts, it looks like it will be transferable. Unfortunately, COVID has made data collection very difficult. So it may have, the feedback might be more patient feedback and staffing feedback rather than data on length of stay and so on. But I think if that feedback is positive, then I think it really puts us into the next phase of such a project. So we have asked Goher if we can actually go to another set of trusts, and that's in consideration. Obviously, that is going to be expensive. But if we go to another set of trusts where, having got over some of the COVID problems, we may be able to get much more accurate data. But whatever, I think the bottom line is it has been an extremely positive experience for all those trusts. Whether that's the way of doing it or whether we should be doing it in different ways, I don't know. I think the key thing about the IP3D project is the engagement of everyone. It really has worked in engagement, and I'm sure you can engage in other ways. But here is something off the shelf that people can use.
And is there a role for the audits? Should this have its own audit, or should it be piggybacked on one or more of the other surgical audits in order to map that implementation?
So GERFT is actually looking at diabetes audits, and the length of stay related to surgical care is going to be one of the markers of good delivery of diabetes stroke perioperative services. I think audits is absolutely essential for driving change. You need to know where you are today, you need to know what that looks like compared to others, and you need to have a desire to improve it. And throughout all the service developments that I've introduced, that has been fundamental to driving change and making not the audit, not just for yourselves, but for other people to be aware of.
Agreed. And Scarlett, I think I saw you put your hand up being very polite.
I just wanted to come in and say what everyone said is really interesting, and it's lovely to see this project working and taking off. But with any kind of change, there are some things that are cheap and free that people can just get started with. So I do encourage people to look at the website, find the guidance on cpoc.org.uk and just look for search, because there are things you can start on it. And there are a lot of enthusiasts that be a pre-op nurse, or there'll be someone that can do the patient information and all that kind of thing to just get started, because there are other things that kind of cost money, and you don't want it to be we can't get into such and such project, therefore we've just got to carry on with our suboptimal care. We need to do everything at once. What it really needs to make change is a funded audit project, and for it to be mandated and part of the payment structure. I'm old enough to remember when hip fracture care was very patchy. And then because there was the database of how each trust compared with another, and we got best practice tariffs, so you get pay withheld unless the patient got to theatre within a certain amount of time, saw a geriatrician, that kind of thing. And suddenly care did change, and it's been changing year on year. So in a similar way, we need these audits, but we need the kind of funding structures to change so that they are essential. But people can start now. And the other thing I just wanted to say that the GERFT project has done very well, encouraging people to go and look and see what other units do well. And if you go and, to Ipswich or somewhere that's doing it well, and just see, send a team or go and listen, and just, it's very empowering for the whole team. People want to be doing good care and sometimes just don't quite know how they could tweak some of their system to improve it. So what everybody's doing is amazing, but everybody needs to do as much as they can do, and some places will be further ahead than others.
Really useful point, Scarlett. And Goher, it's been a theme through a lot of the EBPOM meetings. Can you, i.e. the patients, can you be the ones that help us to change? Because there are a community of patients with diabetes or patient organisations. What do you think the role is for patients to come in and say, have you seen this? would you mind reading it? And these are the things that I think we're going to do together.
I think the patient voice is something that up until maybe the last decade was quite quiet and not listened to very much, and it's sort of coming to the fore in all sorts of ways. And something as simple as having somebody go through the process and feedback can give you such rich information about where the pockets of improvement could be. My only caveat to that is just make sure you get a range of voices because everyone's diabetes varies and everyone is individual, and it's nice to get a good range of experiences to then base your changes from. Certainly there's organisations such as Diabetes UK and the JDRF, the Type 1 Diabetes Charity and other charities that will have ready groups of people and forums to reach out through. And there's a thriving sort of social media network of people as well. If it works for the person that you're trying to benefit, then it's working, surely. So it's not just the matter of did you recover well from the surgery? There's a bigger picture that needs to be considered, a sort of encouraging a more holistic approach to the whole management pathway and dealing with how you implement the guidelines. And I think it does certainly help to listen to the people you're trying to benefit. I don't think you can go wrong there.
Last comments from each of the panellists and then from Dave. So, Emma.
Yeah, just to say, I think the one thing I've heard throughout this session and the one thing that's kind of come back from all the trusts is the importance of opening the channels of communication and creating an environment for shared decision making between the patient, diabetes and surgery. And just to say, one of the trusts that have done that really well have done that by setting up a weekly diabetes MDT, perioperative MDT, and that seems to work really well. And I think it goes back to the point Scarlett was saying, that not all of these changes have to cost extortionate amounts of money, that there are very kind of simple things that trusts can do now and put in place to start addressing some of the guidelines.
Gerry.
The key for our project was actually the perioperative nurse coming from surgery. So the ownership was in surgery rather than in diabetes. We have developed a good business case for others to use. So I know it might seem relatively expensive to have a nurse specifically dedicated to surgery and diabetes, but actually the rewards in terms of length of stay, much better patient outcomes, are just overwhelmingly speak for the development of this role in the future. So for me, that is key, as well as the patient empowerment bit. The perioperative passport has been so helpful to getting the patients to ask questions of the staff of the care that they're delivering. And what's interesting, challenging staff, so to speak, actually is not necessarily challenging it. Actually, if it's done in the correct way, it's discussing what should happen with the other staff. And indeed, initially, the passport was not necessarily welcomed within our wards, but once people started to use it, the staff started to learn from it and they love it. So not only do the patients find that communication through a passport useful, but also the ward staff. So those are the two key things for me. One is having the perioperative nurse, and secondly, having that engagement. And as Emma talked about, having regular meetings with colleagues and promoting the service, and actually the audit feedback to everyone involved in the service.
Well, my takeaway is essentially more trust and improved safety. So if patients or people with diabetes going through this process can feel that they can trust the people that they're in the hands of and feel a part of the process and able to make decisions and question what's going on, keep control if they want to of their diabetes and not if they don't through that process. And know that it's being considered, I think, and improve safety overall.
Thank you. And Dave, any reflections from a CPOC perspective?
Yeah, so I think what I've heard is relatively simple improvements can deliver really important changes, and don't be afraid to use shared learning to lift ideas from elsewhere. It's not about reinventing the wheel. I think Gohar's point about ensuring that, as with everything, but really pay attention to putting the patient at the centre of our thought processes and our changes. And I think there's a key bit here, isn't there, about data collection to help understand the impact that we've done and doing and what we might deliver with this. So I would say finally from CPOC, the guideline is out there. It's no use it sitting on a shelf. Please use it. Please let us know if it doesn't meet your requirements, but use it and don't let it sit on that shelf. Thank you.
Great. Well, Scarlett took the dramatic action of leaving the call in order to have the last word. So Scarlett, as we missed you before, anything you want to add just before we close?
Thank you. Just to say what everyone else has said, it's been fantastic working together. Do use the guidance. Some of it is simple things that you can empower other members of staff and indeed the patients to use. So please use it. Please use it for education. And yeah, that's it really. Thank you. Well done.
Brilliant.
Mike, can I just say from the diabetes community, I would really like to thank CPOC for developing this guidance, and it has been a fantastic experience, and it's going to be so important for our patients. Thank you.
Oh, brilliant. Well, that's great to hear. And I mean, for me, I'm by far from being a diabetic specialist, but it's interesting. The conversation's really been all about pathways and teamwork and engaging with patients and supportive self-management. I don't think we mentioned HbA1c, for example, the more technical elements. So I think there's a really important message there. And thank you so much to the panel and my co-chair, Dave Selwyn. Thank you.
Top Med Talk.
We got a big one coming up, don't we?
We do. We have our combined EBPOM Ireland, EBPOM USA, or EBPOM Dingle, EBPOM Chicago meeting coming up starting September 21, running through September 23. So Tuesday, Wednesday, Thursday, coming soon. So, Desiree, can you still buy tickets for it?
Absolutely. You can go to ebpom.org, book now, book in your ticket as soon as you can. And when you do that, you actually get access, Monty, for the entire year of content that we put on EBPOM. So I know a lot of people are asking, though, about CPD and CME points.
Well, for the meeting itself, if you watch the whole thing, the Royal College of Anaesthetists of Ireland have given us 27 CME credits. It doesn't work for every constituency. So if you're in the USA, for example, for the US component, you can pick up 12 accredited, fully certified, approved points if you follow the processes required. So we'll see you all soon. Desiree, excited?
Okay. Oh, super excited. Wonderful conversations from people from all over the world. We're making the best of this virtual situation. So if you haven't gotten your ticket, ebpom.org, book now. Monty, see you soon.
See you in Ireland soon.
Cheers.